Good afternoon. I'm Helen Ekman, a member of the Sanford Burnham Prebys Community Advisory Board for the NCI Designated Cancer Center. I'm a 30-year-old cancer survivor. I'm stage 4, and I am currently taking a medication that was actually developed here at Sanford Burnham Prebys, and I'm grateful. I'm a married mother of 4 with 9 grandchildren and a full professor at the School of Business at UMass Global. Today, we have a very serious topic that we're talking about, one that affects many lives. And this program is dedicated to the courage of those with cancer, those who love them, and those researching to find the cure. Thank you for joining us today. Medulioblastoma is a most common malignant brain tumor in children. Its rapid growth and tendency to spread through the nervous system make it difficult to treat, and many of the children who develop the disease die from it. Moreover, those who survive treatment often suffer lifelong cognitive defects and develop other cancers later in life. Historically, there has been a gap between what is learned in the research lab and what is done in the clinic. But today we're going to hear from a scientist and a physician changing the field by joining together to fight this deadly disease. This particular partnership between Sanford Burnham Prebys and Rady's Children's Hospital ties the research community with clinicians and patients. What is learned in the lab is put to practice in the clinic. The results we see in the clinic inform our research in the lab and make it better. Now, with state-of-the-art sequencing and analysis technologies, our researchers have found a way to uncover the specifics of each patient's tumor to establish a profile, a fingerprint, if you will, that is used to tailor the therapy. This information is evaluated by a team of experts to classify tumors and to identify optimal therapeutic strategies for each patient with the goal of saving lives and improving care. And the need for these young patients could not be greater. Today, our 2 presenters, and in many cases, heroes, tell us about how they helped patients' families in these exact situations. Before we begin, if you have any questions during or after the presentations, please use the Q&A button on the bottom of your screen to ask them at any time. We will then address the questions following the presentation when we come together to review. Now let's begin with our first presenter. Dr. John Crawford is director of the Neuro-Oncology program at Rady Children's Hospital, San Diego. He is also a professor of clinical neurosciences and pediatrics, director of the Pediatric Neuro-Oncology Fellowship Program, and director of Pediatric Neuro-Oncology Clinical Research at UC San Diego School of Medicine. His research interest is neuroimmunological and neurovirological mechanisms of tumor development, progression, and potential treatment. Welcome, John.
Thank you very much, everybody. And I always like that younger slide. I look in my camera and I see how the gray has creeped in over the years. And I appreciate the very warm welcome introduction. So it is a real pleasure to be a part of this community, the San Diego community, who are making great strides in the field of pediatric neuro-oncology research. And Dr. Wechsler-Reya, who's coming after me, has been a good friend for the last 10 years. And I think we've been doing something very special in our community, and then even giving back to the larger community. So I've been tasked with the next 10 minutes or so just to give a general overview of pediatric neuro-oncology. And in particular, we're going to be discussing precision medicine and neuro-oncology. I don't have any relevant disclosures other than I'm a huge Star Wars fan. You could probably see Yoda in the back and the Millennium Falcon. And this is a collection that I've amassed over the last 4 years, and it makes me smile. So what makes central nervous system cancer so unique? Well, there are a couple elements. Number one are the cells that are involved in the brain and the spinal cord itself. There are cells that aren't in anywhere else in the body. Neurons, oligodendrocytes, axons, microglial cells, its own immune system. And on top of that, there is the blood-brain barrier that really is a filtration system that limits drugs, particularly the ones that we're interested, to enter the brain. And it's been a real challenge within our field. Now, looking back at the history of pediatric neuro-oncology, it's a profession in its infancy. And so even looking back in 1846, which was not too far ago, that was when we first started using anesthesia for surgeries. And then the first stereotactic surgery was in 1947. And then in the 1980s, we began giving chemotherapy for children with brain tumors. And that was a novel concept at the time because it really was just essentially surgery, radiation, and hospice therapy. And then comes the 2000s, where the field underwent this enormous revolution of genetic sequencing. And where we are today is we have the molecular tools to be able to define each patient's tumor and really treat as n equals 1. Looking at the epidemiology of pediatric brain tumors, it's been steady at about 5 per 100,000 per year. And that's been true since the MRI era, which is really in the mid to late 90s. And when you look at the demographics, you can see that the majority of childhood brain tumors ages 0 to 19 years of age are malignant tumors as compared to non-malignant tumors. And that's in contradistinction when you get to adults where there are more non-malignant tumors. And most of those are going to be pituitary tumors and some what we call meningiomas. Now, the statistic that none of us are happy with is in 2014, brain cancer took the lead for the most common cause of death from all of childhood cancer, and it overtook leukemia. And that's a statistic that we'd like to make a major dent in. And one of the problems is those that I've mentioned, really the cells of the brain, the blood-brain barrier, and our limited understanding of how to get drugs into this area. Now, looking at the geographic view of pediatric brain tumors, really the brain is a fascinating place, and these tumors tend to gravitate towards particular areas in the brain. And a lot of that has to do with embryologic origins and where they're developed. And so really, this is just a slide showing you an ABC of neuro-oncology based on geographic location. And what's important is that the presenting features of these tumors really does vary based on anatomic location. And there are a number of signs and symptoms that we consider more classic for brain tumors, such as early morning vomiting and early morning headaches, which is a sign of increased intracranial pressure. But patients can also present with seizures, with weakness, with problems chewing, swallowing, with double vision. And one of the most common symptoms that often is overlooked by patients, physicians, and parents are visual field deficits. Often by the time children present with certain types of tumors, they already have significant visual compromise. Now, this is the historical classification of pediatric brain tumors by the World Health Organization. And this was only about 7 or 8 years ago. The majority of these tumors were classified as tumors of neuroepithelial origin. And there was a time when I could look at this chart, memorize it, and go about my day. And as I'll show you as we fast forward ahead, things have gotten a lot more complicated and certainly for the better. Now, when we look at the historical approach of how we used to diagnose central nervous system tumors, it really began with a large surgery, and it began with a view under the microscope. And we used to define these tumors based upon what are called the histological features, What do the cells look like? How aggressive do they look like? Do they have blood vessel growth? Are there areas of necrosis? And then came along certain stains, immunohistochemistries that we would be able to further subgroup tumors. But at best, this was really a black and white version of a movie that really needs to be in 4K in color. And so here we go, fast forwarding to 2021. And I've depicted here just 6 of the most common pediatric brain tumors: medulloblastoma, ependymoma, low-grade glioma, diffuse midline glioma, infantile gliomas, and atypical teratoid rhabdoid tumors. Now, in the past, at most, there would be 2 or 3 or 4 subcategorizations with these tumors when looking under the microscope. However, because of molecular analysis, we've realized that these tumors are not just 1 disease, 2 diseases, 3 diseases. It becomes more and more complicated by the minute. And through these molecular technologies, including next generation sequencing, RNA sequencing, and expression analysis, and methylation, these tumors are able to be categorized very specifically, and then they're able to be correlated with patient outcomes. And this has really been a game changer for the field and has really led now to what the 2021 classification of tumors looks like. And I put this slide in on purpose. The font is so small that you just need to have a snapshot of everything, and you can see how different the field is right now in terms of how we categorize these tumors. And as Dr. Wechsler-Reya will tell you, it's even more complicated than this. It would probably be about 10 pages if we were to classify it even further. Now, looking at how we treat pediatric central nervous system tumors, not a whole lot has changed. It's still really a triad of therapies in many cases. It begins with neurosurgery, chemotherapy, and in some cases, radiation therapy. And this has been the hallmark of pediatric brain tumor and central nervous system tumor therapy for decades now. However, what we've realized is we don't want our children just to survive, we want them to thrive. And all of these therapies carry toxic effects to the developing brain and the developing central nervous system. And this slide depicts some of the most common potential late effects of chemotherapy and radiation therapy in the treatment of patients with central nervous system cancer. And you can see it essentially affects every single organ. And so what we would like to do is we would like to have more specific therapies that are less toxic for the developing brain. And I always like to say that a picture says 1,000 words. I bribed my 10-year-old daughter on a weekend to draw this picture for me that's going to be featured in an upcoming review article. And I think it just depicts the multi-system organ involvement from our therapies very nicely. Now, what's really important is neuro-oncology spans a lifetime, not just in terms of when patients can develop these tumors, but the children that we treat today, they turn into adults and they need specialized care in terms of tumor monitoring, specialized care in terms of monitoring for secondary malignancies and some of the side effects that I mentioned. So it's very important that we have partners in care as we move along from the pediatric to adult spectrum. Now, one of the things that's most exciting for me, and it's been a real pleasure to be in this field for 15 years now, is the future of neuro-oncology with regards to individualized molecular-based therapies. And when we look at the molecular complexities of pediatric central nervous system tumors, we can now subdivide them into genetic elements, not just within the tumor, but within the germline, within the blood. Epigenetic, what happens on the coding of the DNA that allows expression? The transcriptional level, going from DNA to RNA to protein. What happens at the protein level? What are some of the post-translational modifications that are required? And then lastly, what about the metabolic regulation? What about the immune regulation? These are 2 understudied areas of neuro-oncology, but are very, very important for tumor growth and development. And I always like to say children are not like onions, they're like roses with equal degrees of complexity. So how do we become more precise in our therapies? Well, we need to understand the molecular drivers of the tumor through rapid genetic studies. We need to be able to risk stratify our patients according to the defined genetic drivers and not to the disease itself, meaning not just what it looks like under the microscope, but what are the genetic elements of the tumor. We need to choose smart therapies that have a high likelihood of crossing the brain and into the tumor with minimal side effects. And lastly, if tumor therapies fail, we need to understand why. And because of current technologies, that may require rebiopsying and requerying the tissue to understand the molecular mechanisms of resistance. Now, Dr. Wechsler and I have been on this 10-year journey, and this is where we started 10 years ago. It was essentially a trio of Dr. Levy in the operating room, Dr. Wechsler-Reya and his team collecting tumors from the OR, doing some precursory genetic analysis, and most importantly, injecting them into mice to watch these tumors grow. And then ultimately, the plan was to bring them back to me so that I can treat the patient. Now, what has been really exciting are innovations in neurosurgery that has led to opportunity. And in particular, over the last 5 years, we've been utilizing robotic guided biopsy to allow safe tumor analysis. And this is an extraordinary technology. The patients go home the next day. It's a very, very minimally invasive surgery from the neurosurgeons. We're able to get needle cores of tissue that are just phenomenal for looking under the microscope, for doing genetics, for placing into mice, and what Dr. Wechsler-Reya will talk about, doing real-time drug screening. So now these novel translational approaches have gone from a small team to a very large team that Dr. Wechsler-Reya will discuss. And it really has been one of the highlights in San Diego that's really becoming an envy of the country with how we're approaching these tumors. We have an extraordinary clinical team at Rady Children's Hospital. We've grown by about threefold since I started in 2009. None of this would be possible without our amazing research team. It takes an army to be able to open and to run a clinical trial. And I will end with this slide. And neuro-oncology is a very, very humbling profession. And we have great, great promise in this field. And this reminds me every day of why I'm here and why we all need to be better. This is a picture that I took of my daughter many, many years ago. And she had this very surreal, serene look to herself. And I took the photo and I decided to use some creative liberty. All of those flashing stars in the sky are a patient that I've lost from brain cancer since 2009. So we have a very long way to go, but we're making great strides. So I thank you very much for your attention.
Thank you, John. That was an amazing presentation. And I wanted you to please let Amelia know that we appreciate the picture that she drew. It was excellent. We look forward to hearing from you again later in the program. And next, we're now going to have Dr. Rob Wechsler-Reya. He is the director and professor of the Tumor Initiation and Maintenance Program in the NCI Designated Cancer Center at Sanford Burnham Prebys. Dr. Wechsler-Reya's research focuses on the brain tumor, the Medulioblastoma. He studies the relationship between brain development and brain tumor formation. Welcome, Rob. Really glad to have you here.
Thank you very much, Helen, and it's a real pleasure to be here. So I have the distinct pleasure of working together with John Crawford on the clinical side of things, but also with an incredibly talented group of postdocs and graduate students in my lab. And what I thought I'd do today is spend a few minutes just telling you about some of the research we've been doing in my lab, and then show you how that has led to a clinical trial that John and I are working on together at Rady. Really, a major focus of the work that we do in my lab is on animal models and using animal models as a tool to try to understand the biology of medulloblastoma and other pediatric brain tumors. Medulloblastoma, as you've heard, is the most common malignant brain tumor in children. This is an extremely aggressive tumor that, if left untreated, will grow rapidly, spread through the central nervous system, and invariably kill the patient. Now, that's if left untreated. As you've heard from John already, we rarely leave these kids untreated. In fact, we treat them extremely aggressively with a combination of surgery, radiation, and chemotherapy. And these approaches do prolong survival, but ultimately many patients relapse. And those who don't relapse and survive end up suffering severe long-term side effects from the therapy. And so a major goal of the work that we're doing is to try to improve those outcomes by understanding the tumor better. Now, as I said, we use models of medulloblastoma, and we use two major kinds of models, what we call genetically engineered mice, or GEMs. And these are made by either introducing a mutation in the DNA of an animal or introducing cells that have a mutation in their DNA into the brain of a mouse. And either way, these mice will grow tumors that resemble human medulloblastoma and allow us to study the disease. This is a valuable tool, but at the end of the day, these are mouse tumors growing in a mouse. And what we'd really like is to understand human tumors. And so through an incredible collaboration with John Crawford and Mike Levy, the neurosurgeon, we've been able to also make patient-derived xenograft models, or PDXs. And these models are generated by getting tumor cells from the operating room at the time of surgery, bringing them back to the lab, and injecting them into the brain of a mouse, where they can continue to grow as they were growing in the original patient. And these tools allow us to study actual human tumors and to test their responsiveness to therapies. So the combination of these two approaches, GEM models and PDX models, are really powerful at giving us insight into the disease. So models allow us to study which normal cells give rise to tumors. As John said, there are many different cell types in the brain, and neurons and astrocytes and their progenitors have all been implicated as cells of origin for these diseases. If we understand the normal cells that give rise to the tumor, we can begin to determine what went wrong and how we can correct it. We can ask, what are the genetic mutations that turn these normal cells into tumors? And we can ask, what are the vulnerabilities of tumor cells and which drugs can we use to target them? And finally, we can ask whether the immune system can be trained to attack tumors so that we're not just throwing toxic chemicals and radiation at the tumor, but actually getting the patient's own body to begin to help us eradicate the tumor. So I'm just going to show you two quick snapshots of some things we're doing in my lab. One of the major oncogenes, or cancer-causing genes, that is a driver of medulloblastoma is called MYC. And MYC is an important gene in many different kinds of cancer, but using our models, using our PDX models, and an incredible facility at Sanford Burnham Prebys, we have been able to do a screen to try to find drugs that shut off the activity of MYC and thereby hopefully shut off the activity of the tumor. And this just shows an example where each frame here is a set of cells that are treated with increasing concentrations of the drug we've identified. And you can see that the yellow spots, which represent the levels of the MYC protein, are going down. The more drug you give, the less MYC there is. And we're working on developing this into a drug that can be used in animals and ultimately in patients, that we hope will be an important tool in the fight against medulloblastoma and other cancers. As I mentioned, we're also interested in training the immune system to attack tumors. And this just shows that in our animal models, when they have tumors growing in their brain, if we get rid of a particular type of immune cell, the CD4 T cell, now the tumors grow much more aggressively. And that suggests that these cells are playing an important role in fighting the tumor. And we've confirmed that because if we give mice more CD4 T cells, now they survive much longer, and some of the animals don't end up succumbing to the disease. So we're hoping to develop this into a strategy for immunotherapy for kids with brain tumors. But one of the most powerful things that we can do using our models is to use them to try to identify existing drugs that are not commonly used against medulloblastoma, but that we can find are effective. And if we're able to do this repurposing act, if we're able to take drugs that were developed for another disease and use them to fight medulloblastoma, we can go much more quickly from the lab to the clinic and really have an impact on patient survival. And our ability to do this has really been facilitated by an incredible resource that Sanford Burnham Prebys has called the Conrad Prebys Center for Chemical Genomics. This center includes a high throughput drug screening facility. And what you're looking at here is a plastic dish with tens of little wells in which there are cells. And these little pipettes are spitting different drugs into each one of these wells. And this technology has really been transformative because in the past, if you were really good, you could test 1 or 2 or 10 different drugs to see if they would work on the particular tumor you're working on. This robotic facility allows us to begin to test hundreds or even thousands of drugs. And this makes the progress towards finding a curative drug much, much faster. And so we used this facility to do a screen where we took 3,600 compounds, including many FDA-approved drugs and drugs that are in clinical trials. We put those into the plastic wells, and then we added into those wells cells from our mouse models of medulloblastoma. And then we simply asked, after 48 hours, which drugs were able to kill tumor cells. And what we found is that out of the 3,600 compounds, only a subset, about 140, could kill our GEM models, our mouse medulloblastoma cells. And among those drugs, only 50 of them could also kill human medulloblastoma cells. And then we further narrowed down our list by looking for things that do not kill normal brain cells, normal glial cells, and normal neurons. And at the end of this, out of 3,600 compounds, we had only 27 that were good candidates for treating medulloblastoma. And among these, several of them were drugs called histone deacetylase or HDAC inhibitors, and others were PI3 kinase inhibitors. And these are 2 classes of drugs that have been in trials for a number of other cancers, but have not been used extensively for medulloblastoma. And what we found is that when we took these drugs on their own, they were certainly capable of inhibiting growth. This is the PI3 kinase inhibitor. This is the HDAC inhibitor, and they all reduce cell survival substantially over giving no drug, but the combination was much more effective than either drug alone. And so that was in vitro in a dish, and then we tried this combination in vivo in mice. And what you can see is animals, each pair of animals here is a time point, and after 3 time points, the mice have to be sacrificed. If you give either the PI3 kinase inhibitor or the HDAC inhibitor, the mice live a little bit longer, but the combination really significantly prolongs survival. And this is shown in this survival curve here, where you can see that animals getting no drug survive for only about 30 days, but we can more than double the median survival if these animals are given this combination of drugs. And this was really promising. And for the type of medulloblastoma we were studying, this looked like the most effective therapy we'd seen. And so we worked with a national organization called the Pediatric Neuro-Oncology Consortium, or PNOC, to develop a clinical trial that is the title of which is here. This is a drug called fimipinostat, which is a single drug that does what the 2 different drugs we had been testing do. It inhibits both HDAC and PI3 kinase. And this trial is underway. It's being tested on children with recurrent medulloblastoma and also for kids with high-grade glioma. So we're really excited to see whether this drug makes a difference in the survival of these kids with incredibly aggressive tumors. Now, the question is, this drug screening that we did on our animal models, is it just a tool for the lab? Or could we actually use this approach to identify drugs that work for individual patients in the clinic? And so I'm going to invite John to come back on so that we can talk a little bit about our precision medicine approach. And welcome back, John. So I'll keep talking, but feel free to interrupt, and certainly when we get to the questions, you can definitely answer some better than I can. So just to reiterate a couple of the things that John said, brain tumors, although they occur in kids and they're not as common as adult tumors, they're incredibly aggressive and they're incredibly heterogeneous. So this is a blow up of two of the things that John showed on his slide, where you can see that there are 4 major types of medulloblastoma, and each of them has 3 or 4 major subtypes. So in all, maybe 12 different kinds of medulloblastoma, 9 different kinds of ependymoma, and every pediatric brain tumor has this heterogeneity. And yet, as John mentioned, every patient gets more or less the same therapy: surgery to remove the tumor if it can be removed, radiation, except in very young kids, and a combination of really toxic chemotherapy agents. And together, this is our toolbox for treating pediatric brain tumors. But despite this, outcomes remain very poor. For brainstem glioma, almost all of the patients die within 2 years. And for medulloblastoma, the survival is a little bit better, but the side effects are devastating. So cognitive decline, in this case, showing 20 to 25-point drops in IQ after treatment for medulloblastoma. So we really need to do much better. And the question is, can precision medicine help? Can tailoring the right therapy for the right patient make a difference in the outcomes for these kids? Now, the problem is when we talk about precision medicine generally for adults, what we're talking about is sequencing the DNA, looking for those mutations that might be causing the tumor, and then finding drugs that might be effective against those mutations. The problem is for many pediatric brain tumors, there are no mutations, or at least we haven't found them. And when we have found them, there aren't often drugs against them. And so simply sequencing the DNA of a kid's tumor is not necessarily going to give us a better approach to therapy. And so what we've done instead is to take a multimodal approach. Instead of just sequencing the DNA, we also sequence the RNA, which is the sort of messenger that goes between the DNA and the protein within cells. We look at the DNA methylation patterns, that is, the marks on the DNA that tell whether a gene should be turned on or off. And then we do the same kind of high throughput drug screening that I described to you that we're doing in our animal models. And when a patient comes through this process, after a couple of weeks, we gather all the data and we meet as a molecular tumor board. That includes physicians, it includes computational biologists, it includes cancer biologists, and we all put our heads together and say, what is the tumor we're dealing with, and what is our best shot at therapy for this patient? Over the last year, we've done 18 cases, and I won't go through these in detail, but a variety of different disease types, including medulloblastoma and ependymoma. And for every one of these patients, we've learned more than we would have with conventional approaches to diagnosis and treatment. So I'm just going to take you very quickly through one case that we did recently that used all of these tools to our advantage. This was a 2-month-old that presented with whole body shaking and vomiting. The patient was irritable in the ER and had eye deviation and a bulging fontanelle on the top of the head. The MRI that was done showed a large mass, and the pathology showed very aggressive, highly proliferative tumor cells. And so based on this, all we could say is this is a very high-grade aggressive tumor. But when we did this DNA methylation analysis, looking at the marks on the DNA, it was very clear that this was a rare but recognized type of tumor called an infantile hemispheric glioma. And simply knowing that actually changes the approach to therapy, knowing what tumor you're dealing with. And then we did DNA and RNA sequencing, and this is actually not from this patient, but it's to illustrate a point, which is that the sequencing highlighted a fusion, a piece of one chromosome that popped off and fused to another chromosome. And this brought 2 different pieces of DNA encoding 2 different genes together. And this made those genes function abnormally. And so these 2 genes that were brought together are called GAB1 and ABL1. And it turns out that ABL1 is a protein for which there is a drug. We also did high throughput drug screening and RNA analysis. And again, among the drugs that we found were inhibitors of this ABL protein that suggested that they might be highly effective against this child's tumor. And so all of the data were coming together, pointing to a group of inhibitors that we could use potentially for this patient. Unfortunately, this patient died very quickly, as often happens with infant tumors. And before we could deploy any of these therapies, the patient died. And so what we learned from this is that doing all of this analysis, sequencing, RNA analysis, DNA analysis, and drug screening can come together in some cases to point to an effective therapy. And we hope that going forward, we'll be able to do this on patients who have a little bit more time and be able to test whether this approach can improve outcomes for these kids. So with that in mind, John and I have designed a clinical trial. It has a very long title, but illustrates what we're trying to do here, to test the benefit of real-time drug screening to determine individualized treatment plans for children and young adults with relapsed or refractory medulloblastoma. And it involves all the techniques that we've described. We were fortunate enough to get funding from Padres Pedal the Cause, which is an incredible organization in San Diego that funds collaborative grants between Rady, UCSD, Sanford Burnham Prebys, and Salk. And again, we get all of the data on these kids together, we bring it to the molecular tumor board, and we try to find the best therapy for each individual patient. As John said, this takes an army, and this is part of the army. These are some of the members of the molecular tumor board, and as I said, include physicians, pathologists, neurosurgeons, as well as computational biologists, and some incredibly talented people, including a couple of my lab members. Actually, everyone in my lab participates in this process. And so we're really excited to have moved as far as we can, but especially excited to move forward and see if we can make a dent in these incredibly aggressive tumors. The scientific work I showed you earlier on was done by students and postdocs from my lab, depicted here. And these are the members of my lab outside our building. I won't go through one by one all of our funding sources, but you can see Padres Pedal the Cause, NIH, St. Baldrick's, and others, and our collaborators from many institutions around the world. So with that, happy to shut off my slides and take whatever questions together with John that you may have.
Thank you both, and say that this is an incredible collaboration, and I'm really thrilled with what you're doing here. And thank you. So our first question, and I'd like to remind the audience, if you have questions, just go ahead and put them in the Q&A section and we'll try to get to them. So our first question is, are there drugs that can be given to help with the side effects of chemo and radiation?
That is a very, very good question. We do have drugs that can help with some of the side effects, such as nausea and vomiting. And actually, we have very good drugs that can help with that. There are actually some drugs now that we have to help protect the hearing in patients that get cisplatin chemotherapy. So that certainly can help. We're still stuck with the age-old therapy of steroids, which really does wonders in terms of its anti-inflammatory properties, but we know it's a double-edged sword. And the one missing piece that we would really like to have is a therapy that helps protect the brain with regards to the IQ effects from radiation. And that's something that is still a real black box that we'd like to make some progress.
Absolutely. We pray that you do. So here's another question. Who ultimately is responsible for coordinating a child's cancer treatment? The oncologist, the radiologist, the parent? Who's the quarterback?
Yeah, that's a great question. You know, I suppose that I'm the quarterback, or at least I have been since 2009, but it is a multi-collaborative approach. So I would say that everybody has the chance to throw the ball, not just the quarterback. Everybody has the chance to punt the ball. And it really is a coordinated effort. But as with everything in medicine, you do need one person as the point person, and usually that's the neuro-oncologist. So we have 3 of them at Rady Children's Hospital. Myself, Dr. Paul, and Dr. Elster are the quarterbacks.
Great, thank you. So here's another question. Can stem cell therapy be used for pediatric brain tumors?
Boy, that's another great question. How come they're all my questions? So
you're the quarterback, John.
I guess so. We do use stem cells from a patient's own bone marrow. It's called high-dose chemotherapy with autologous stem cell rescue. But I think the notion of using pluripotent cells from the lab is something that is still under study. And it's being studied now for stroke and other neurodegenerative diseases. But I think in neuro-oncology, we have a ways to go for stem cell therapy. The field is going now more in the immunotherapy route with CAR T cell therapy, and less in the way, and more vaccine therapies and less in the way of specific stem cell therapies.
Okay. So I'll chime in just a little. I think John made an important distinction between blood stem cells, which are used to rescue from the side effects of chemotherapy and radiation. There is another class of stem cells called neural stem cells that people are experimenting with in two ways. One, to try to repair some of that damage that's being done when we irradiate the brain. Those studies are really far in their infancy. Very hard to get those cells, very hard to train them to do what we want them to do. So those are experiments that are in the early stages in animals, but I'm very hopeful that down the road we might be able to use them. There's also a number of groups that are trying to use stem cells as a tool for delivering therapies. And again, we're far from that being effective in the clinic, but just for people to know that we're trying a lot of things. We're using stem cells as tools to try to approach repairing brain damage and delivering therapies.
Okay. Are you able to map changes in tumor pathways to stay ahead of drug resistance?
Yeah, I wish we were better at it. It's a great idea. It's a really important notion. I think that one of the keys is what John mentioned, which is the ability to sample the tumor repeatedly using these robotic biopsies. Yes. And it's hard to it's hard not to stress how unique and important this is, because historically biopsies have been very crude and quite dangerous. And with robotic guided, very fine needle biopsies, you can now go in, and John will tell you this in more detail, pull multiple pieces of tissue from a patient without causing damage or side effects. And that means that you can give a patient a therapy, and if the tumor comes back, rather than giving them a new therapy based on what you learned about their tumor 3 or 6 months ago, you can give them a new therapy based on what their tumor looks like now. Yes. And so the ability to sample using biopsy is really critical to doing what the questioner asked.
Okay, we have another question here. Thank you very much, Rob and John. It's from the person attending. And great to understand more depth to your very complex clinical research and care. You mentioned, Rob, that many pediatric brain tumors have no mutations. Can you talk about the significance of that and how much that impacts treatment options, please?
Yeah. It's very perplexing because the history of cancer biology is all about mutations. It's all about finding a gene in which there's an error and then predicting what that error does and how can we circumvent it. And there are certainly cases like that for pediatric brain tumors. But a lot of patients, when we sequence their tumor, we either find no mutations at all, or we find mutations in genes that we don't understand and don't have a drug for. And so some of this is our own ignorance. As we go forward, we're going to be able to look back at some of those patients and say, oh, well, this is a mutation that we actually know causes the disease, and we could develop a drug against it. But I think a lot of it has to do with the way pediatric brain tumors arise, and that is from cells early in development. And during development, when the body is being created, there's a tremendous amount of cell division, there's a tremendous amount of plasticity. And so when something goes wrong in a cell at that stage, sometimes you don't actually need a mutation. The cell is wired to keep proliferating as long as you don't shut it off. And if you somehow deregulate it, that cell now becomes a tumor. And so what we're talking about are the properties of the cells of origin, the cells from which the tumor comes. And we're also talking about epigenetic changes, that is, things that are not mistakes in the DNA, but mistakes in the marking, the highlighting and crossing out of DNA that every cell in our body does. And those can't be discovered using conventional sequencing approaches. They have to be discovered using novel approaches that are just coming online now.
That was a great answer. Thank you. Is there a mechanism for a small biotech startup with limited funds to collaborate with your team to screen novel small molecules? So here we have somebody who's asking that question.
Yeah, there are definitely mechanisms. I'd be happy to talk offline. I think we are doing quite a number of collaborations already, and often it's a question of bandwidth and funding. But I'm always happy to learn about new approaches, and if it's the kind of thing that could be incorporated into screens that we're already doing, that wouldn't be very tough.
Okay. So, and I think your way to be contacted will be on the final screen. So good. Are you finding now that we use multiple chemos at one time to target different parts of the tumor, or do you have to wait and do one drug at a time?
That's my favorite question so far. So
Yes.
I can tell you one of the most frustrating things that I had seen early on in my training is the one drug at one time approach.
Mm-hmm.
And I think there were multiple reasons for that. But what we have now with all of these technologies and this information, the patients and their families are asking us to do more,
Mm-hmm.
not one at a time. And so we just completed a trial with diffuse intrinsic pontine glioma, taking a similar approach with the molecular tumor board, where these patients had up to 4 drugs at one time with no complaints. And so I think what this has really led to is the fact that cancer is smart. There's not just one pathway. When something gets blocked, the tumors find a new pathway to chug along, and we need to keep up with them, which really means multi-targeted therapies. So that's exactly what we're doing. I sure hope the day of single agent therapies for brain cancer is long gone.
Great. Okay. Is there any attempt to create immunogenic cell death that will create danger signals to recruit the immune cells, sort of creating self-vaccination against the tumor? I'm not sure I understood
say yes
the question.
And leave it at that, but
okay, yes. Okay.
No, it's a really interesting strategy. The immunotherapies are a really striking field, because the notion that you could use the immune system to target cancer is about 120 years old. And people have been trying desperately for that long and really have only had success in the last few years. But the success has been really exciting because it's opened up a whole bunch of different avenues for getting the immune system to recognize the tumor and then kill it. Yes. And the approach that the questioner is asking about is one of several strategies that's being tested. If we can get the tumor cells to reveal themselves to the immune system, if we can activate the cells of the immune system, the T cells and the B cells and the macrophages, if we can bring those cells into the tumor, because they won't do any good if they can't get into the tumor, any of those strategies is going to help. And so I think that what we need to do is we don't have a clear, solid understanding of how the immune system functions in the brain and in brain tumors. And so we need to learn a lot more about the basic biology. And at the same time, we need to test some of these approaches and really see which ones are making a difference. So this biopsy approach that we talked about doesn't have to just work to sample the tumor and see what to treat it with. We can also use biopsy to see what happened to the tumor after we gave a therapy. If we were trying to make the tumor hot, that is recognizable to the immune system, did the drug we gave work? If it didn't work, what went wrong? And so I think there's a much more dynamic learning process that we need to engage in to be able to move forward.
That sounds really promising. So do you give chemo before surgery if you get a biopsy and can match an effective drug, or is it always surgery first?
Well, that's a great question. It is surgery first, but here's the big question. Does it need to be a big surgery first? Can we not use the robotic technologies to cheat, to give us a heads up about what are the molecular aspects of this before surgery? And a little bit, in order to make this happen, there's going to have to be a paradigm shift, right? And so sometimes doing things in a non-classic way can ruffle some feathers, but I think Rob and I are in complete agreement that for some of these tumors, we should be querying up front. So we know it's a group 3 medulloblastoma right before the surgeon goes in. And that's exactly the time to be able to maybe think about some of these novel biologics before surgery.
I think the parents that are listening here are saying, yes, ruffle feathers. Do that, please. Okay. If my child's cancer reoccurs after remission, is there any chance that it can go into remission again?
Yes. It's a complicated question. It depends on what the first tumor was. It depends on the molecular genetic makeup. Depends on a lot of factors, but yes, there are always opportunities for second and third and fourth and fifth remissions, depending on the tumor type.
Yes, as someone who's sitting here stage 4 cancer, yes. Can parents choose a novel experimental treatment instead of the standard care? Do parents have that option?
I think they should have that option. And that's really where clinical trials come into play, because clinical trials are experimental by definition. So I strongly encourage every patient to go on a clinical trial. The reason why those leukemia survivals have done so well is because of collaborative clinical trials treating patients in a standardized fashion. So I'm a big believer in trials.
Like this collaboration. Do you employ PK/PD modeling in helping you bridge the data from the animal models to get a starting dose for the patient?
Short answer is yes. We work with, so things that have gone to clinical trials, like for example, that drug that targets the 2 pathways. There's extensive work that's done, whether it's by us or by the drug company that developed it, depends on on the specific drug. But it's really important to recognize that models are models, and that, curing tumor in a mouse is a big feat, but it's nowhere near curing tumor in a patient. And so we need to take what we learned from the animal models. Ideally, we use the animal models to rule out things that are not worth trying in patients. And then for the things that are worth trying, we just hope that some of them will work.
Yes.
And among the things that are barriers to the drug working are the blood-brain barrier and other pharmacologic properties. So it's critical to do PK/PD analysis. These
are our last 3 questions. Okay, everybody ready? So yes, there will be a recording available after this. So that's questions answered. Have you started using protemic and metabolic approaches in biopsies? You can say yes or no.
We would love to. So, proteomics is a field that is just lagging behind the genomics because of the technologies. I remember in graduate school, the only way to do these protein maps is to run these gels in 2 different directions and stain them with, they look like spots on a cow. The technologies have improved significantly, but they're not as real time and fast as we would like them. So Rob and I do have collaborators that are doing proteomics, but it is a work in progress. And in terms of the metabolomics, we have a physician here at UCSD, Jong Ro, who's a world expert in ketogenic diet and metabolism for epilepsy, that I've been twisting his arm to join the dark side of neuro-oncology. And if it weren't for COVID, he would have done that already, but he is definitely on the team, and we would love to get those studies underway. Our tissue is available for all researchers. You know, we want many more players on the team. We want to triple the size of that slide.
Yes. Okay. If a biopsy is not possible, are there any other ways to understand the tumor, perhaps in the CSF? I could be reading that wrong.
Yeah. So CSF is cerebrospinal fluid, and that's the fluid that bathes the brain and spinal cord. And when you do a spinal tap, that's what you're sampling.
Okay.
Yes, there are new technologies. They're not yet standardized, but technologies for trying to find markers of the tumor in the cerebrospinal fluid and in the blood. And when those get just a little bit better, they're going to be incredibly valuable tools. They may obviate the need to do some biopsies, but great. We're not quite there yet.
Okay, so our last question is, are there any results from the Fimepostat trial? Did I say it right?
Fimepostat. And there are no results yet. In fact, it's still open and accruing patients. So it's going to take some time.
Stay tuned.
Okay, I want to say thank you to the audience who's been so involved in this and has asked so many good questions. I want to thank both of you for your hearts and your minds and for the way that you're caring for our children. Thank you. So thank you to our speakers, and thank you all for joining us. As always, our presentation was recorded, and here is the email where you can help us support these researchers, giving at sbpsdiscovery.org. If you want to help support this good research, we would really appreciate it. And you can learn about other research that's going on, including breast cancer research, which has been important to me. Thank you for attending today. Again, feel free to share with your friends and colleagues, and thank you for your interest in our science. Have a wonderful afternoon.